you very much, Dr. Wong, and thank you very much for Dr. Lazarus and Dr. Rinella for the great first talks. So it's true. Now I'm going to talk about MetALD. We all knew that we have those patients where the metabolic dysfunction is leading the process. Then you have the patient where is clearly only alcohol. But what happened with those patients that are in the middle? Those ones that have, dual etiology or, where there is some overlap between both. So these are my disclosures. So today we are going to discuss, the overlapping features between MASLD and ALD, try to understand a little bit on the epidemiology of MetALD, and then recognize the importance of distinguishing MASLD from ALD. So this is from the WHO, what are the risk factors for liver disease? And if you look how things has been doing over the years, the main two risk factors are alcohol and obesity. And all of us that practice, in a liver clinic, you can tell that most of your patients are either MASLD or ALD. So addressing these two issues, probably we are addressing a significant portion of patients with liver disease. Alcohol consumption is very common. So 43% of the global population will consume any degree of alcohol. This varies across the globe. The alcohol per capita consumption in average is 6.4 liters, or this was in 2016, but is close to 10 to 12 in Europe, and other region is close to 3. So there is variability across the globe. And you can say how in the different regions is very different. Also with the type of alcohol consumed, so this also varies across the globe. In general, the most consumed are spirits, followed by beer and then wine. And it's not only the amount, it's also, the pattern of alcohol consumption, and you can have what we call heavy episodic drinking. And this is also very frequent. You can see how in some places can be as frequent as 60% of the population having a pattern of alcohol consumption in heavy episodic drinking. And some of those patients are going to meet the criteria for an alcohol use disorder, which is actually, is categorized in the psychiatric community in the DSM-5 as a specific criteria where there is lack of control and you continue drinking despite the physical, social, and family consequences. And you can see how globally AUD prevalence is 5.1%, but it's as high as 8.8% in some regions in Europe. And correlating with all these, you can see how MASLD and alcohol are both the most important or growing causes for liver transplantation, at least in the US, especially for male is alcohol, for females it's MASH, but alcohol is very close to that one. So Dr. Rinella already explained you how we have this spectrum of steatotic liver disease. That is what you are going to find when a patient comes to your clinic with an ultrasound with steatosis. You need to define where in the spectrum is this patient, and I'm going to focus in the middle in the MetALD category. So if you look the spectrum, and this is using data from the US with the National Care Survey, you can see how close to 38% of the population is going to have a steatotic liver disease, 32% MASLD, 2.5% MetALD, and 1% ALD. This is one study. This is another one with similar numbers. So still, we are talking about a very significant proportion of the population. So let's try to dig into some of the questions that we have for the future in MetALD. Let's start with patient care. So is there any safe threshold for alcohol consumption in patients with MASLD? And the short answer is probably not. And this is not only coming from the population with MASLD, but if you even look in the general population, a significant amount of studies are showing that there is no safety threshold, especially if you are less than 60 years old. Any amount of alcohol is going to start producing, any type of disease burden. And that's why here in Canada, the recommendation for low alcohol drinking was changed 2 years ago. And it used to be more than 7 drinks per week in females and more than 2 per day, so 14 per week. For males was considered heavy drinking. Now heavy drinking is defined as 7 per week, both male or females, and low alcohol or low risk is actually less than 2. Zero risk, obviously, 0. So the message of this is probably the amount of alcohol is likely lower than what we think before. Another question, so how is light, moderate, or heavy alcohol consumption is going to impact the course of the liver disease in MASLD? This is a spectrum. And obviously, if you drink alcohol and you have isolated steatosis, it's not the same that if you drink alcohol, if you have cirrhosis. And we will need more data on the specific of this, but this makes sense in the context that also alcohol-related liver disease is also on a spectrum, also has steatosis, steatohepatitis, and then fibrosis, leading to cirrhosis and all the complications. And we need to consider that abstinence, when you have liver disease, alcohol-related liver disease, is one of the most strongest predictors for outcomes. I like pretty much this figure because basically exemplify the speed of progression of the disease. If you have MASLD and you are F1, your risk, 5-year risk of decompensation is less than 1%. If you are alcohol, is 2 to 15%. If you are F3, F4, and you are MASLD, it's 5 to 15%. But if you are F4 and you are ALD, your 5 risk of decompensation is up to 50%. So alcohol is a driver of disease that probably is putting a significant burden there. How is the interaction? So from a pathophysiological standpoint, we know that both are going to generate some, direct toxicity, either lipotoxicity or toxicity secondary to alcohol, that is going to be gut-liver axis dysfunction, and at the end is going to lead to more inflammatory process and apoptosis. Any specific biomarkers, and this is probably one of the key questions, because now we are basically relying on the patient report, but do we have any biomarkers? There is nothing ready from the prime time, but I think more research is needed in this field. So can we, for example, use exosomes, circulating exosomes, or microRNAs, or protein, or lipidomics, or proteomics that can help us to risk stratify and do diagnosis in this population? What about genetic polymorphisms? That's another important one. So there is plenty of genetic polymorphism that apply for this dual etiology because they have been shown to be predictive in both MASLD and ALD. And if you look, and this is a very interesting study, if you look, if you have the polymorphism, actually the highest risk of developing cirrhosis is when you combine excessive alcohol drinking and obesity. So you don't only have to have the polymorphism or one of the injuries. If you have both, this is one of the situations where 1 + 1 is not 2 and can be 4 or 8 in this case. And then we need to have, public health policies, as Jeff was mentioning, so we can tackle this disease one patient at a time. We need to implement, for example, public health policies on healthy lifestyles, on healthy diet, but also restricting alcohol consumption in a way that we don't have the harm over the population. From a clinical research perspective and therapeutic trials, so one problem is the underreported of alcohol consumption. So we need to identify patients that has alcohol use disorder. So one of them is using the audit score. There is also a shorter version, which is called the audit C, that only consider 3 of the questions. And I think this should be a screening for all patients with SLD, because when the patient comes to you, you don't know if the SLD is due to MASLD, is MetALD, is ALD, or is any of the specific etiologies. But alcohol biomarkers, that's the other way. So if we can rely 100% on the report, can we have something else? And this is a very interesting study coming from Austria, where they did in a NAFLD clinic at that time, patient with diagnosis of NAFLD or MAFLD, and they did an alcohol biomarker in hair called ethylglucuronide, and they found that these patients that were classified as NAFLD or MAFLD between 25 to 28% were actually heavy alcohol consumption. So we shouldn't only rely on the report, because usually alcohol is underreported because of the stigma or because the patient doesn't remember exactly how much he was drinking. Then, so some of the therapies that are developed for MASLD can be applied for MetALD. Now we have resmetirom approved for MASLD. Can resmetirom be used for MetALD or other of the drugs? There is multiple drugs coming on the pipeline. So I think this is going to be the next step, how we can apply the knowledge that we are generating in both fields, either MASLD or ALD, in the MetALD population. So as a summary, MASLD and ALD are leading cause of chronic liver disease worldwide, and these are frequently overlap. The new definition consider those patients in the intersection or the dual etiology between MASLD and increased alcohol consumption. Usually, we need to identify alcohol because it's underreported, and maybe biomarkers is a good opportunity. We should prescribe to every patient healthy diet, physical activity, as well as promotion of abstinence, of minimization of alcohol intake. And then we have many questions for further research in this field from a clinical perspective, from a biomarker perspective, and then how we assess the new therapies in these new entities. Thank you very much, and I will be happy to take questions.